Okay, I think we're going to get started. Good afternoon and welcome to the CDC's Hemoglobinopathy webinar series. I'm Gretchen Simmons from the Division of Blood Disorders, and I'll be serving as today's moderator. Before we start the presentation, I just want to go over a few points. As the conference leader, I will now mute all the conference lines to eliminate background noise. After the presentation, we'll allow questions, and you'll have to press *6 to individually unmute your line at that time. Since we can't actually see who wishes to make a comment, please electronically raise your hand if you wish to speak. To raise your hand, click on the Q&A tab on the menu bar of your webinar screen. In the Q&A window, click on the hand icon in the upper right corner. This will display your name to the meeting presenters. I will call on participants as their names are displayed. You can raise your hand during the presentation, but we'll wait until the discussion period to address those comments. Also, this session is being recorded. And today's topic is improving quality of care for sickle cell pediatrics in the emergency department. Our presenter, Dr. James Moses, is a graduate of the University of Chicago Pritzker School of Medicine. He completed his medical training at the Boston Combined Residency Program in Pediatrics at Boston Children's Hospital and the Boston Medical Center. Afterwards, James received further training as a fellow in the Pediatric Harvard Health Services Research Fellowship, where he attained his Master's in Public Health degree in Clinical Effectiveness. He now serves as the Pediatric Director of Quality and Patient Safety for the Department of Pediatrics at the Boston Medical Center. James received formal training in quality improvement through the Improvement Advisor Program at the Institute for Healthcare Improvement. And in his role as the Pediatric Director of Quality and Safety, James oversees all quality improvement-related initiatives within his department. At this time, will Dr. Moses please unmute his phone by pressing *6 to begin addressing the audience? Dr. Moses?
Yes, hi there.
Hi.
Sorry, when I pushed it, I went on to mute.
No problem.
All right. Well, thank you very much for having me. I'm excited to really have the next hour to discuss our project in the Pediatric Emergency Department. As the title says, we really looked at improving our time to initial pain medication for sickle cell patients presenting with pain episodes in our pediatric ED. I'm glad to be here to share all of this with you guys on the call. So just to start with some disclosures, part of the effort in our pediatric ED was supported locally through a local endowment, and some of this work was supported by a Noonan grant as well. And then most recently, and actually more specifically, our Quality Improvement Initiative has been directly supported by a grant from HRSA, the Health Resources and Service Administration. I think the other thing to disclose is I'm not a hematologist and I'm not a sickle cell disease expert, but in essence, I think as my bio kind of explained, more here because of the quality and the quality improvement expertise and really having that be a part of the discussion today. Next slide. So I thought it would be really good to start just with putting the Quality Improvement Initiative here in a larger context of what I would call the quality gap in sickle cell disease and medical care. And then we'll talk a little bit more specifically about just historically some of the barriers to effective pain management coming from the emergency department, both in pediatrics as well as in adults. We'll then go through my Quality Improvement Initiative a little bit at a closer level so that you can see directly kind of what our learning process was, and I can share that with you. And then we'll conclude and we'll go on from there to have a question and answer session. So moving into the quality gap piece. So I think as most of us on the phone call know, there's in 1970 there was Robert Scott's seminal reports that really kind of brought to national and international attention the kind of health disparity that exists in sickle cell disease. Specifically the lack of national attention kind of directed toward improving outcomes for that population. And that led to the National Sickle Cell Anemia Control Act in 1972 that created these 10 comprehensive care centers with direct funding from NIH really focused on identifying therapeutic advancements through clinical research studies to advance care for this important population. So some of those advancements, and the ones that, at least for us in pediatrics, are important, are listed here. So penicillin prophylaxis, hydroxyurea, bone marrow transplant, and so on. These are a lot of the treatment advancements that came out of that effort that now are standard of care. Next slide. I think the piece here is that despite these therapeutic medical advances, there still continues to be widespread variation in care that continues. And this really has created a gap that exists really between these advances in medical care and their effective use in practice. And that's really preventing the improvement in clinical outcomes for this population from being really as strong and achieving as much as we can for this population. It's really preventing it from being achieved. So some examples of this, at least for us in pediatrics, is when you take a look at penicillin prophylaxis, one study demonstrated that children only received enough antibiotics to cover 40% of the year. Another paper brought to light that there are significant barriers to transcranial Doppler screening, and in that specific study population demonstrated that only 41 to 51% of those eligible patients were actually being screened on an annual basis. And then more at the 30,000-foot view, there's a striking disparity that exists between the private and public funding for cystic fibrosis, which is a similar genetically inheritable disease, but that is less prevalent than sickle cell disease. That, in essence, for every $1 spent on sickle cell disease, there's $9 spent on cystic fibrosis. Next slide. So it's not to say that this hasn't been recognized. So HRSA has followed in 2004 with the Sickle Cell Treatment Act that really authorized HRSA to fund up to 40 federally qualified healthcare centers via a competitive grant program, specifically with the emphasis on medical treatment, education, and other services for sickle cell patients. And this really is just a response to say we need to be doing more to ensure that patients are getting the care that they need to get in order to make sure that their health outcomes are as good as we can make them. Okay. Now let's move into kind of historically where ED pain management has been and talk about the barriers tied to that. So specifically for this population, pain episodes are the most common reason for going to the emergency room. And most patients go to the emergency department only after exhausting all of their home pain management options. And that high-frequency users of the ED tend to have more severe disease and more complications.
Dr. Moses, can I ask you to pause for a minute? We're getting a lot of background noise, and I'm going to try and remute the lines.
Okay.
Sorry. Okay, go ahead.
All right. Can you hear me?
Yes.
Okay. All right. Next slide. All right. So given what we were just discussing, obviously I think that it's pretty obvious that there is a need for patients who are coming to the emergency department to have rapid assessment and treatment. And this has been recognized really by leading organizations in this field. And more locally, colleagues of ours here at the Boston Medical Center looked really with the help of an expert panel to establish quality indicators for pediatric sickle cell disease. And what was interesting out of that work was that timely pain assessment and treatment for pain episodes received the highest ratings by that expert panel.
Is there a signing sheet?
So that led to really an established metric that really is starting to be one of the defining metrics for pain management in the emergency department, which is that all patients should receive their initial parenteral opioid medication within 30 minutes of arrival. But when you actually go into the literature to see what the kind of current reports are about timeliness of that initial pain medication, it's not great. So in pediatrics, there's been reports of, on average, of 69 to 90 minutes for that initial pain medication to be given to patients, and that's similar in the adult literature as well. You can see here where it says 74 to 80 minutes. So why is that? So I think we all have experienced and seen, that there are specific barriers that affect the ED's ability to deliver timely pain management. So in the literature specifically, that has been ED crowding. So obviously a busier ED is going to have a harder time making sure that they're able to get pain medication to their patients in a timely manner. The severity of pain on presentation, as well as the level of acuity assigned at triage, can also impact the timeliness of the initial pain medication. And then there's patient factors such as age and language barriers that can impact that as well. And then I also think quite notably is the provider attitude. The assumptions of drug-seeking behavior, especially with high utilizers who we know to have more complications and more severe disease. And then I think race as well as class are also elements in why there isn't timely pain management. So now let's move into our specific initiative in the pediatric ED here at the Boston Medical Center. So our effort really came out of a qualitative research effort that one of my colleagues did here, where they specifically looked at parents with children with sickle cell disease and adolescents with sickle cell disease and did an assessment of what they would characterize as their unmet need in the care that they received from our department. Next slide, yeah. So it was through focus groups and interviews that this work was done.
I'm sorry, Dr. Moses.
Yep.
Let me interrupt for just a moment. I was finally able to log on as a leader, so I'm going to mute all the lines first.
Okay.
And once that's complete, I'll have you unmute your phone.
Okay. Okay.
The conference is now in silent mode.
Okay, Dr. Moses, when you can, press *6.
All right.
Great. Thank you
Good.
so much, and I apologize.
No worries. No worries. All right. So coming out of that effort really was one of the major themes was that our ED care was suboptimal. Next slide. So I just have some quotes here in the next couple of slides just to share with you so you guys can get a sense of specifically the patient perspective. So there was a recognition that the ED does work hard. The emergency room, they do their best to keep me comfortable, and I usually feel better when I come in because they give me pain medicine. They do all the tests there to figure out what's really going on, so the emergency room is just fine. So despite thinking, giving really the benefit of the doubt to the ED staff, there was a perception that there were delays in pain medications. The residents are like, well, we're waiting for the hematologist to call back. So then I'll just say, do you want me to tell you what they usually do? Because they usually start him on an IV now because he's in a lot of pain. And they'll say, okay, we can try that. There's also was apparent that there was underdosing of pain medications. Because sometimes he'll be like, Mommy, can I get some painkillers? They'll give him painkillers, but sometimes they might give him something not as strong as needed to soothe the pain. They might give him something and it doesn't really help. He needs something stronger. And he's like, where's the doctor? Another theme was intravenous access issues. I have horrible veins because I've been stuck every month this year. So it takes 8 sticks or 5 sticks usually to actually get an IV in. And by the 5th or 8th stick, I'm absolutely done. I cry. There's also a theme of how this impacted the admissions process as well. The amount of time it took from the ER to upstairs, I think we came around 3 in the afternoon and we didn't get upstairs until 8. I mean, that's too long. They want food and they're crying and they're tired. So after that research effort was completed, it became pretty apparent that we needed to address those specific concerns in our pediatric ED. And in essence, we had our why defined. We had unmet needs, and we needed to improve our care. And we really had the direction of what we wanted to achieve. It quickly came upon the specific focus of improving our time to initial pain medication to 30 minutes or less for patients who were presenting with who had sickle cell disease who were presenting with pain episodes to our pediatric ED. I think the only question for us that we couldn't answer was how were we going to get this done? And there's a famous quote by Paul Batalden, who's a quality improvement expert, where he says, every system is perfectly designed to get the results it gets. And I can say that this was very true for us here at the pediatric, for our pediatric emergency department here at the Boston Medical Center. So just to give everybody on the call a sense of the clinical setting, we're a 16-bed emergency department, and of those 16 beds, 5 of them are actually acute beds, and you typically staffed by a nurse. Sometimes it can be 2 nurses depending on the number of patients that are there. And from a physician standpoint, there's 1 pediatric ED attending, maybe with a fellow, and then more typically with 4 or 5 residents who are taking care of all the patients. And we're the second busiest pediatric ED in Massachusetts. We have up to 28,000 visits annually. And we are the safety net hospital for really the Boston area, and which really is just to say that there's been a number of fiscal limitations to our ability to kind of adequately staff our ED and have robust systems of care that really facilitate high-quality care for our patients. To give you guys some concrete examples of that, there's an EMR limitation here at BMC where the electronic medical record system in our emergency department is different than the one that exists in our outpatient facilities, and that's different from the one that we have on the inpatient services. And that really limits our ability to kind of deliver care along continuum. You can imagine that's very impactful on getting a real sense of a patient's history, especially a complicated one, of a patient who has chronic disease such as sickle cell disease. And it also doesn't allow us to create pain management plans from an outpatient standpoint and have them assimilated into the EMR in our pediatric ED. This also has been impactful of our staffing in the ED from a nursing standpoint, that really the staffing has been cut down to the bare minimum, which doesn't really allow for the kind of rapid facilitation of pain medication. The staffing definitely is impactful on that. And then recently, we had a day hospital that was dedicated to the sickle cell patients that recently closed. And so within this context, there has been a greater reliance on the ED for pain management for this population, which has really kind of made this a high priority for us here at the Boston Medical Center. The other piece I would say is, quality improvement is not something that has been part of our system here for a long time. It's relatively new to our staff. And there's also an element that from an ED perspective, that there were a lot of kind of resistance and barriers to change. Here I put here that system's not really seen as broken, and that the pain is not really seen as a treatment priority the same as a kind of acute respiratory distress or a trauma patient is seen. And then the other piece is that from an IT perspective, we really don't have a system that's built around rapid tests of change, which is what's needed from a quality improvement standpoint. And our providers are not used to testing ideas informally. I would say that we're very much a historical culture around that research is really the only true way to test concepts. And quality improvement kind of flips that over and says that there's a way that we can actually informally test ideas and to more rapidly improve care. So that's a bit of the context of our effort here at the Boston Medical Center. So I'm specifically trained in the model for improvement. I don't know how many people on the call are familiar with this, but in essence, this is the framework that for quality improvement where you really set specific aims of what you want to accomplish. In order to know if your changes are leading to improvement, you need to establish a family of measures. Then there's some strategies within this framework around identifying what changes to start with. And then we use the plan, do, study, act cycles to test changes and eventually get to the point of implementation. Stepping back, this is really my definition of quality improvement. I see it as iterative cycles of testing to learn what changes can be made to improve care process with a very strong emphasis on learning by that testing. This comes with the primary assumption that solutions are best identified by testing in actual clinical settings with multidisciplinary input. And an effective strategy for QI is really to start small and then spread your tests of change as your degree of belief in your changes bringing about improvement grows. So this was our multidisciplinary team. So I really represented the QI expertise, but we had pediatric physician providers, specifically ED pharmacy providers represented on our team, social work, ED nursing. We actually had someone from IT join us. We had a patient representative. Our PD hematologist joined us, and we have a general academic researcher here who actually did the qualitative research effort, who also was part of our multidisciplinary team. And to give you also initial sense of what our initial process was before we started testing in our treatment of pain episodes, I felt it was important to show you the step-by-step care process. So specifically, patients come to the ED, that they're rapidly seen in triage and placed on the acute side. And there used to be a determination of, should we start them on oral pain medications or should we go right to intravenous? And then IV would be placed. And usually at that time, pediatric hematology would be called to get recommended medications and dosing. And then the pain medications would be given intravenously. And then after 2 or 3 doses, a decision to admit or not would be made. And if we decide to admit a patient, a PCA, a patient-controlled analgesia machine would be started, and the patients would go up to the inpatient service after admission. And I put this slide in here to really just emphasize this is what we started with. We really didn't have an idea at this point how our system was performing, and we didn't really have an idea of the answers that were going to fix our system. We did have a lot of questions, though. So some of our questions in the beginning were how long are patients waiting in the ED prior to their initial assessment, and can we expedite that process? And then once they're assessed, how long do they wait to receive their initial pain medications? What is the best timing for pediatric hematology input? We wanted to know if patient satisfaction would improve if we really improved the care processes to get pain medication to be more timely. And so what we needed was really a tool to help our learning process, specifically really with 2 purposes. One is to help us identify problems in care and facilitate a constant feedback loop with us, the multidisciplinary team, based on learning from each care patient encounter. But we also needed a tool to kind of be able to prompt the care providers in the ED about what the appropriate steps in care were. And so we decided to create a checklist and informally test that right away in our pediatric ED. Part of this was also making sure that we had the right measurement system to know if these changes were going to lead to improvement. And so what you can see here is our outcome measures. Obviously, it's the time to initial pain medication, but we also put patient satisfaction there initially. And then our process measures were really kind of every single step in the care process. We wanted to know the timing to that. And so they really allowed us to learn how effective each step in the care process was. And then balancing measures are really measures that you should incorporate into any quality improvement project to make sure your changes are not having a negative impact on your system of care. And when we were brainstorming about that, we felt it was really important to come up with a process that the staff could buy into. And so we wanted to make sure that we could maintain staff satisfaction with the care process. And then patient satisfaction scores we also put here, and I'll get into that a little bit later in the presentation. So this slide represents our initial results. So we quickly introduced this checklist to get a sense of where our baseline performance was. And we saw that it was not great, which kind of makes sense given what we learned from the qualitative interviews, that our time to initial pain medication was 75 minutes. So though our performance wasn't great, we did learn from that initial test of change. We learned that a checklist can actually be successfully used in the ED for pain episodes, but that really without having any time-specific goals incorporated into that tool, we weren't going to realize improvement. And we felt kind of initially that probably one of the major drivers to our delay in initial pain medication was that it's really difficult, given access issues, to get IV in consistently within 30 minutes. We decided that we needed to further test with an improved checklist to see if we could bring about an improvement. So our next cycle led to including time-specific goals on that checklist, really making it more of a guideline slash algorithm to kind of drive the streamlining of care within our pediatric ED. And then we really hadn't yet figured out what to do with starting patients on oral pain medications or not when they were coming into the ED. And so we decided to say, why don't we start everybody on oral pain medications who had not taken their pain medication within 4 hours prior to the ED. And then the other piece we emphasized to the ED providers that if there are IV access issues, stop after 3 sticks and give a subcutaneous dose to get a pain medication on board, and then you can refocus in on getting IV access. And this was also the point in which we introduced really a non-validated, locally derived patient satisfaction tool that was really just a way for us to have feedback on more immediately on were we impacting patient satisfaction. So what you can see here was that the intervention was relatively successful. We didn't reach our goal, but that our checklist with time-specific goals dropped our time to initial pain management from 75 minutes down to 46 minutes. I also outlined here where you can see the first pain medication being oral. And in essence, what we learned was that it's a lot easier to give something orally initially than IV, yet there were a number of patients that did receive their first pain medication via IV first, implying that many of them were adequately and appropriately taking their home pain medications and only coming into ED as a last resort. And you also can see that there's one patient who had a subcutaneous dose. So we also were using the checklist slash algorithm to really try to pick up what were the factors that were leading to delays. And this slide gets to some of them. What you can see is that IV access issues were definitely predominant, but that having a busy ED also was impactful. Having unclear kind of directions around dosing and medications was also impactful. And then having a patient go to radiology to get a chest x-ray or to get other imaging was also something that would delay time to pain medication. Here were our initial patient satisfaction scores. You can see, so 5 being the very best and 0 really being poor satisfaction with care. And despite our current the performance at that time, patient satisfaction was relatively high. I think that what we learned is that patients knew what to expect by coming to the ED, and so they had accepted the level of performance that we were giving them, and so we're relatively rating it high. But I think that they were, in essence, being too nice, and I think that that was going to be something that we would have to track. So again, just to recap, we learned that the oral route obviously is faster than IV, but we did learn that most patients taking oral pain medication within 4 hours of ED presentation was going to prevent it from being 100% the route we would use to deliver first pain medication. It's also not fast acting and therefore not really ideal as a first-line agent. And of the patient who received the subcutaneous dose, he reported that he'd rather get stuck 6 to 7 times for an IV than get another subcutaneous dose. So that wasn't really an effective strategy either. We did continue to confirm this difficulty with intravenous access. And then, as I said before, we learned that patients are happy with care. And what I put here is that it means that our efforts weren't going to be about improving patient satisfaction, that our efforts were becoming about maintaining patient satisfaction. So making sure that patient satisfaction did not go down with our new interventions moving forward. So we were stuck, and we really needed to figure out what was going to be another strategy for us to ensure that we were able to give a timely and effective dose of pain medication within 30 minutes of a patient arriving in our ED. And it was in one of our meetings when one of our colleagues raised the possibility of using intranasal fentanyl. And the nice thing about intranasal fentanyl is that it has a fast onset of action, 5 to 10 minutes, and it lasts for about half an hour to 30 to 40 minutes, which is kind of buys enough time waiting for the IV to come in for subsequent dosing. And it bypasses the slow uptake from the gastrointestinal tract. So it's systemic distribution that's, it's very fast acting, and we were intrigued by that. Looking into its use for sickle cell disease, it's not widely used. It's not a typical pain agent that has been reported in the literature. It has been very well described for other etiologies to pain, such as long bone fractures and other conditions such as like perioperative pain. But those are more typical for narcotic-naive populations, and we didn't really know if there was going to be a benefit for a non-narcotic naive patient, such as a patient with sickle cell disease who's coming into the ED multiple times. There is one report by Telfer et al. About the use of intranasal diamorphine for sickle cell patients that did show effectiveness, but it was a small study, and it had yet to really lead to kind of any widespread change in emergency department-based management of pain. So we went ahead and with the concept of testing intranasal fentanyl, and we saw a dramatic decrease in our time to pain medication. So we went now from 75 minutes down to 46 minutes, now down to about 20 minutes, 19 to 20 minutes with intranasal fentanyl. You can see that's with 6 or 7 data points. So each data point here represents a patient. And so really this is with the first 6 patients. The 19 minutes wasn't something that was going to be a definitive result. Next slide, yeah. But what we did learn from testing it on such a small scale is that we were able to get the ED to give it in a timely manner. That this wasn't something that the nurses in our ED were typically giving to patients, but we were able to get them comfortable with the process, and that it was something that we were able to prove that it was feasible to get done. What we learned about the effectiveness is that there were definitely some patients who had benefits, and the IV access issues continued on happening, so we saw immediately the potential of getting something on board while IV access continues on trying to be attained. But we only tested with one delivery of the medication because, at least in the U.S., the concentration of intranasal fentanyl is not concentrated enough to give a larger patient or a fully grown patient just one dose. That really an appropriate dose for anybody who's greater than 64 kilograms should get 2 doses of this. But given that this was quality improvement and we just wanted to test really feasibility, we gave them 1 dose because we wanted to see how they would like it or not like it and make sure that they tolerated it. We did learn that it was well tolerated, that there were some mild complaints of irritation, but that no one had really an adverse reaction to it, and that all the patients reasonably felt it was reasonable to give within their pain management. So that was important for us as well. So that was about 14 to 18 months ago, and we've been continuing along our quality improvement journey, and really have kind of moved this checklist that then became a guideline to really pushing this concept of streamlined steps of care. That one of the mental models that we've been trying to express to our doctors in the ED is about asthma. So if you take asthma, they will give albuterol nebs back-to-back and steroids without thinking about it. And we've really kind of pushed them to use the same kind of concept with sickle cell patients around giving the intranasal fentanyl followed by intravenous doses with the same kind of regularity and consistency. We've now made it so that everybody gets 2 doses of intranasal fentanyl when they first come into our emergency department. And the other result of this has been that the pediatric hematology input that usually occurred before the first intravenous dose, we've realized that by standardizing our pain protocol, that really their input is needed more at the point of deciding to admit a patient or not, and starting the PCA, that we've removed the extra steps of calling them and waiting for them to give kind of very specific doses to the team, because that was something that was really not facilitating timely pain delivery. You know, to give somebody a pain medication within 30 minutes, it needs to be much more automatic than that. The other thing that we did was, I forgot to mention this limitation in our EMR. So the EMR, the electronic medical record system in our pediatric emergency department, does not have a weight-based calculator that's built into it, meaning that the providers have to calculate by hand and then input electronically the medication, and then the nurses who are doing the double check have to also do it by hand, and then to make sure that the doctors came up with the right dose. And so that was also a huge inefficiency. And so we created a pain medication calculator that I'll show you in a couple slides down. And then, though not affecting our timeliness to initial pain medication, but with some of the focus on getting those subsequent steps in care to be just as timely, we got new PCA pumps that were much easier to program from a nursing standpoint, and we were hopeful that that would benefit the patient experience as well. So this is the guideline/protocol as it currently stands. Who's ever moving the presentation, I have a couple of animations if you can push. Great. So you can see that we give 2 doses of intranasal fentanyl, followed by 2 doses of the intravenous opioid pain medication, followed by what that's supposed to say, a decision to either start PCA and admit the patient, or to transition them to orals and to send them home. This is our pain medication calculator. If you basically all this requires is for the providers to put in the weight and the age, and then once they push return, all the doses that they could possibly want get auto-calculated. So this is where we are at now. So in essence, we've moved down to, or really it's been maintaining our gain of where we've been able to maintain the timing of first pain medication to about 22 to 23 minutes, which is something we're pretty proud of. This has also had a benefit. These streamlined steps in care have had a benefit to the subsequent steps in care. So this is our timing to our second IV dose. And I just want to point out that the earlier time just reflects that the second opioid IV dose actually was the second pain medication dose the patients were receiving. But now the second IV dose represents theoretically the 4th pain medication to be given to the patient, because they're getting 2 intranasal fentanyls followed by 2 IVs. So the fact that our timing still went down was a good result for us. We are not close to our goal. We're trying to get this less than an hour, which is really aggressive, but this is at least a step in the right direction. This is our timing to PCA initiation, so getting the upfront steps in care to happen in a more streamlined way has had a direct benefit to decreasing the timing to PCA initiation for our patients who are admitted. This is in sequence and kind of makes sense that this is tied to the decision to admit, which has also showed an improvement. And then lastly, on the next slide, is our discharge time. So for the patients that can transition to orals, we've also dramatically decreased the timing where they are able to be discharged home. So I thought that a good way to kind of cap everything would be to show you our key driver diagram. Hopefully the animations will work. But in essence, this is a schematic that shows you our theories of what leads to timely pain medication. And it's very locally, the local context of your quality improvement project is what leads to this. These are not final answers or perfect answers. This is just to explain to you guys what we think led to the improvement. So the first piece is you need timely medication ordering, both the physician ordering and the nursing double check. There needs to be an efficient process for that. Keep on clicking through. Yeah, that the route of medication delivery is really important. We saw oral versus IV versus intranasal versus subcutaneous having an impact on your ability to get to your pain medications within 30 minutes. Then having a shared mental model. The fact that we were able to push the pediatric hematology input to later means that came with their consent because they knew what the upfront steps in care would be. So the secondary drivers lead to the primary drivers. So in order to have timely medication ordering, you need to have a patient who gets placed in their bed quickly. You need to have a doctor who sees them quickly. And you need to have a nurse who, in a timely way, can do the double check. And the more standardized your calculation of appropriate medication doses can be, the more timely your medication ordering will be. The standardization also leads to your route of medication delivery being more consistent. And then, again, with the pediatric ED providers and hematology staff, having them aware of the treatment plan and having patients and families also aware of the steps in care is important to establishing the shared mental model. So timely bed placement and timely physician assessment is tied to really timely triage. Our pain medication calculator facilitated directly the timeliness that an RN is able to double check the ordering of physicians. And as well as ordering of the physician ordering of medication, as well as the physician process. And then the algorithm/guideline really helped us create that shared mental model and standardize our process. And then the last two pieces were education for our providers, as well as education for our patients. So as we head toward trying to make sure that this is sustainable over the long term, some questions that we still need to answer is a checklist and guideline needed, or can we assimilate this somehow into our EMR? Can we actually sustain our results? So if we stop meeting and stop talking to the ED, will they be able to maintain this going forward? And buy-in continues on being an issue where there's still this question of why is there so much focus on this specific subpopulation when there's other populations that visit the ED more often. So our next steps, we have just obtained an IV visualizer that uses infrared technology that we're hoping will help with more immediate IV access. It's been shown to decrease the number of sticks. Hopefully that will prove to actually be the case. We're continuing on refining the intranasal fentanyl and the guideline. And again, this question of can we assimilate the guideline into the EMR? Just to go through some conclusions, and then we can get to the Q&A. I hope through this presentation you guys can see from a quality improvement standpoint how quality improvement can provide a way for us to more immediately improve our systems of care. That it's really based on this like repeated testing to learn what's going to be most effective within the system. That there's a real importance of multidisciplinary input to guide the chosen interventions, especially needing to have patients and families involved in that. And that you can start small, and then as you're learning, as you become more confident in your chosen interventions through learning, you can build your scale of your test up from there. You know, our quality journey with the sickle cell disease patients presenting with pain episodes really have led us to continuously have discussions. I think when we started out, we assumed that we were just going to have patient-specific pain plans for every single patient in our ED. And I still think that's going to be a long-term goal. I still think it's a goal. But we ended up emphasizing more just upfront standardization of care because we felt from an ED standpoint that was going to be something that would drive care more immediately to be better. There's also this piece of ideal care, less than 30 minutes for initial IV dose, versus other routes versus care in reality. I don't know if we're ever going to get to the point of being able to 100% guarantee that every single patient coming in with a pain episode is going to get their pain medication within 30 minutes. I think it's a great goal, but the EDs can be busy, and there is a reality to trying to get this done in emergency departments. I think the other piece we realize is, the timing to first pain medication is just the first factor of the equation of pain control. And just because you get pain medication on board in a timely way does not equate to pain relief for a patient. And the subsequent steps are just as important as that first pain medication, and making sure that the pain medications are effective regardless of their timing is really important. And then the other piece for us was the patient satisfaction of really trying to raise the bar in the sense of their understanding of our clinical care process and our ED. How it moves from an outcome measure to a balancing measure. I think that hopefully as we improve our care, that I think that they'll realize just the quality gap that does exist, and I think we'll continue to track that moving forward. This is just the bibliography, so I think we can move to any questions that you guys might have.
Great. Thank you, Dr. Moses. We have about 15 minutes remaining, so we'll now open the lines for questions. Please remember to unmute your phone individually by pressing *6. If you have a question, raise your hand electronically, and your names will be called in the order in which they're received. We only have this line for about an hour, so I will need to end the session when we reach that time. So if you do have questions, please make sure to go ahead and raise your hand. You can do that by clicking on the Q&A tab on the menu bar of your webinar screen. And in that Q&A window, click on the hand icon up in the upper right corner. Judith?
Hi, yes. At the very conclusion, you talk a little bit about patient satisfaction and time to pain control. And I know that this is not completely what you were presenting to us, but do you have any feedback on how the fentanyl worked in terms of time to pain control, patient satisfaction? Was it improved? Any other feedback on that aspect?
Yeah, thank you so much for that question. So I should have, I'm realizing now that I didn't include the patient satisfaction run chart over time. So it really has remained the same. The care continues to be rated in that 4 to 5 area on the Likert scale. And I would say that the intranasal fentanyl definitely has some limitations. So I think the older population doesn't get as much benefit from it as the younger population. That's not 100% consistent across the board. We've had plenty of 20-year-olds and 21-year-olds who have had a lot of benefit from the intranasal fentanyl, but it does seem to be something that is patient-specific. And it does make the concept of standardization, an interesting question that if only some patients are responding to this, is this something that that every single patient should get? I think our decision from a quality improvement standpoint has been that it's really not intranasal fentanyl in and of itself, but it's intranasal fentanyl in conjunction with the subsequent intravenous dosing of pain medication. And it's that package that needs to go together. And so we found overall that patient satisfaction has been maintained, and it's something that we're continuing on monitoring, because I think it's also our way of making sure that we're serving the patients in the right way, making sure that our patient experience is being maintained.
But it doesn't seem as if you really have it. You haven't really found out if you've improved patient care. You've improved the time scale, but is there a measure to say that you've improved the actual patient care, because they've been satisfied with you from the very beginning?
Yeah.
Have you measured time to pain relief or things like that?
Yeah. So I think you raised a very good question. I think that we have been following, I think the more objective measure for us, which is still not a great measure, and I think it's an interesting discussion, what is an accurate and objective measure for time to pain relief? But using pain scales, we've seen a drop in pain, in reported pain. that has been in the, in the scale that is used in our emergency department. We've also seen an increase in the amount of patients who've been able to get discharged from our emergency department versus admitted. But neither of those metrics is a perfect metric of effectiveness of care. And it's just I think it's one of the many issues that that this area is got to navigate. I think that the objective kind of assessment of pain control and when that is achieved, especially in the context of a pain episode, I think at least those are the two metrics we're using from a proxy standpoint to have a sense that our intervention has been more effective than what we had previously.
Thank you.
Thanks, Judith. Great questions. Does anyone else in the audience have a question? Just a reminder to unmute your phone by pressing *6 and then raise your hand. No questions? Okay. Well, if there are no other questions, Judith, do you have another question?
How did you dose the fentanyl?
Yeah. So the hopefully I don't have the specific dosing on me, but what hopefully we can do this is hopefully I can send it to the CDC that they can share with you guys.
Yes, we'd be glad to include that with the PDF of the presentation when we archive it online.
Was that the remainder of your questions, Judith, or did you have additional questions?
No, that was all. That was all. Thank you.
Okay. Anyone else? Connie?
Hello, this is Lisa Monty.
Hello.
Go ahead.
Connie. This is Connie. Are you going to publish this data? Is this going to be publishable and referenceable data on intranasal fentanyl for patients?
Yeah. So we are going to publish this as a quality improvement project. There was IRB approval that we got, but it's really going to be a quality improvement report. And then there's actually a formal trial that I believe is happening in New York to take a look at this from a research standpoint. But I think this will be out there for people to reference moving forward pretty shortly.
Thank you. Larry Allen?
Thank you. Thank you for the presentation. I was just wondering, you made a statement about the ER doctors inquiring about why this subset of your patient community. I guess what I'm trying to figure out is, were you guys having issues with or complaints from patients prior, or was this something you guys decided to tackle on your own? And do the ER doctors have any understanding of what some sickle cell patients have in experience in terms of ER treatment in the past?
Yeah, it's a great question. So, I think that the culture here was an assumption that especially in our ED, to be frank, was that I think the care for this patient population was adequate. So we have 200 sickle cell patients for Pediatrics that we take care of here at the Boston Medical Center, and 500 or 600 adult patients. And so it's more of that there's been a long-standing culture of this being a normal way to take care of them. And it was more the perception that we understood that there to be a problem. I think the interviews with the patients, it was really able to get at their dissatisfaction with the ED care and the times that I think some of the themes that came out of there was that their pain was ignored and not really treated aggressively. That wasn't something that the ED providers were aware of until we brought it to them. And so I think, they do their very best under this system, and I see it as much more of a system output where they are working hard, but something where, like sickle cell disease pain, where you have to be on top of it, give repeated dosings that are timely, and when you're in a busy ED, I think it's hard for them to maintain that focus.
Thank you. Lisa Monty? Lisa, are you there?
Yes,
Remember to unmute your phone by pressing *6.
Can you hear me?
Yes.
Okay, thank you for the presentation. My question is, what is the best approach that you can advise if it's acknowledged that this is a big problem for ER, for the emergency rooms? The doctors are overwhelmed, the patients need assistance right away, but yet some are misinterpreted. Where do we start?
Yeah, so I think that where I would suggest starting is really starting with the champions that you can identify that care about this issue. So we were lucky to have an attending ED provider as well as a staff nurse provider who felt very strongly about this effort. And if it wasn't for their ability to kind of help us and guide us about what interventions were going to be effective for the ED, and then help us communicate those interventions so that the staff in our ED could buy into it, I don't think we would have been successful. So I think first and foremost it's identifying the people that can be champions this for you, and then not everything needs to start with, I think intranasal fentanyl is working for RED. It doesn't necessarily mean that it's something that's going to work across the board. I think that the other elements of our intervention was just focusing in on the care process in the ED and trying to make it more expedited, taking away the barriers and the inefficiencies in their care process. That has actually led to buy-in. They loved the pain medication calculator that we created for them because that was such a barrier. And something that was frustrating them. And we wouldn't have come up with that if it wasn't for the ED nurse and physician provider on our care team. And so I would recommend their input. I think having patients and patients' involvement on quality improvement, but also patients as educators. If you can engage them when a patient tells their story, and you can actually have that patient narrative as part of the education to providers, they realize the problem in a different kind of way versus if I had gotten up there and done a PowerPoint presentation, they wouldn't have bought into it. But when a patient tells their story, staff tends to buy into it to a higher degree.
Okay, second part. I believe that I've identified the champions, and I have the stories, though when I'm asked how, what specifically?
Yeah, how do you start?
Yes, like what did you do?
Yeah, so we started by learning what was broken. I think you need to have a sense of where your rate limiting steps are, and the way that we figured that out was with that initial checklist that wasn't to be used to drive care to be better, not yet. In that very early phase, it was just asking folks to tell us in real time what they were doing when they were doing it. And then when we were able to take a look at that initial data, we had every single step in the care process with the time associated with it. Okay. And we saw that our patients got put into their beds really, really quickly, that they got put in the acute side, and then they waited and waited and waited for that first pain medication. And then we were able to bring that data to the ED. But that informed our process.
Okay.
Okay, thank you. I have one last question I think we might have time for, submitted by Dwight online, and I'll read it to you. It's a two-part question. The first is, did you get any pushback from pharmacy and therapeutics on nurse-driven intranasal fentanyl?
Yeah, so I wouldn't characterize it as nursing-driven because there's still a physician that orders it first, but it was taking both the physicians and nurses, getting them to work together to make it happen. The pharmacy was facilitative of that process. They were a major facilitator of making sure that the supplies were appropriate down in our pediatric ED. They did a lot of the research to ensure its safety and efficacy. And so I can say that there wasn't pushback. They were actually very, very helpful.
Okay, and the second part of this question was anything done differently with patients receiving the intranasal fentanyl at triage that had to wait for a room in the ED, or did they go back to the waiting room like normal?
Yeah, so they always in our process, they get triaged, and from triage, they get to a bed. They never have to go back to the waiting room. And it's once they get into a bed that they get the intranasal fentanyl. What we just found out about our process was that it was that upfront piece that was already in place. We didn't have to make that happen. That was already something that was already happening. But they already got a high level of acuity assigned to them in triage, and then were able to be immediately put into a bed for the most part.
Great, thanks. Our time is up for this session. Is it possible for you to provide your contact information, Dr. Moses?
Yep, I'd be more than happy to.
Okay, great. And the last webinar for this year will take place Thursday, October 25th on strategies from the field data collection and harmonization with the RUSH project states. If you have any questions, please feel free to contact Shay Pope at spope@cdc.gov. And just so everyone knows, the recorded webinars are made available at scinfo.org under the webinars toolbar. Did you want to give that contact information out over the phone?
Yep, I can. My email address is james.moses@bmc.org. That's probably going to be the best way to reach me. My office phone is 617-414-3571.
Great. Thank you so much, and thank you, everyone, for participating.
Thank you very much.
Thanks. Bye-bye, everyone.